sorry, Prof. Lender, maybe I can go to my friends here who join with us now. Selamat pagi teman-teman semua. Telah hadir bersama kita di sini ada Prof. Roger Lender. Thank you very much, Prof. Roger Lender, Prof. Lender atas for your kindness to share with us here. Jadi teman-teman, ini sebenarnya acara pertama kita, yaitu Meet Friends Around the World. Harapannya nanti ke depannya akan ada acara lagi serupa dengan pertemuan bersama apoteker di negara lain. Jadi ada beberapa yang sudah bersedia untuk berbagi dengan teman-teman di sini. Kebetulan itu adalah teman saya di saat ikut Farmasi Kongres di Abu Dhabi. Jadi ada Kak Sosmita di Amerika juga ada tadi Kak Jenny, juga ada Kak J. Catherine, dan juga ada Pak Pharm dari Pakistan. Jadi nanti mungkin kita akan arrange sesuai dengan kesediaan waktu dari para teman apoteker kita yang ada di luar Indonesia. Nah, acara hari ini nanti akan dipandu oleh Kak Kevin. Kak Kevin, terima kasih banyak. Nanti mungkin Kak Kevin bisa memperkenalkan diri juga. Ini sudah jam 8, mungkin bisa langsung saja Kak Kevin untuk memulai. Dan di sini sebenarnya kita juga live di YouTube, tapi room Zoom kita ada 500, jadi teman-teman boleh ajak teman-teman yang lain untuk bergabung. Kurang lebih nanti kita sampai jam 9 untuk acara hari ini. Terima kasih banyak Kak Kevin, silahkan Kak.
Yeah. So just to let Prof. Randa know what Fitria was sharing is about, this is a very interesting session, and then we are very glad to have pharmacists from the US to actually share with us. We'll have a few more projects in the coming months where we'll have pharmacists from around the world. But Prof. Randa, you are the first one. So yeah, and our friend, we are also live on YouTube. So I'll be sharing my screen to kick off our meeting today, discussion basically. Okay. So yep. So I think teman-teman semua hari ini ya saya sudah tadi memperkenalkan Fitria sudah memperkenalkan diri. Sekarang giliran saya ada Kevin, saya apoteker dari Singapura, tapi sekarang saya juga lagi proses penyetaraan dan sedang proses penyetaraan di Universitas Pancasila, dan semoga ya amin ya tahun ini sudah bisa jadi APT di Indonesia. Nah, terus saya akan mempersiapkan Fitria untuk memperkenalkan tentang apa ya apoteker peduli AMR. Silakan Fitria.
Oke, terima kasih Kak Kevin. Ini aku dalam bahasa Indonesia apa bahasa Inggris, Kak?
Bahasa Indonesia aja deh.
Oke, siap. Terima kasih Kak Kevin. Ini kami sangat senang karena ini adalah pertama kali kami melaksanakan kegiatan Meet Friends Around the World. Dan ini sebenarnya proyeknya dari tim Education on Social Media. Jadi ada beberapa program di tim edukasi sosial media itu nanti akan saya sampaikan. Sebelumnya mohon izin, Prof. Lender, I speak in Indonesia, sorry. Jadi apa ini adalah sebenarnya adalah komunitas yang dibentuk dari inisiasi apoteker di beberapa wilayah di Indonesia. Kita berkolaborasi untuk awalnya adalah kegiatan dalam rangka WAAW, World Antimicrobial Awareness Week, itu tahun 2019. Tapi ternyata 2019 kita lakukan di tempat kita masing-masing, kita sharing kegiatan kita. Kemudian di 2020 kita juga masih melakukan hal yang sama. Nah, di 2021 sepertinya kita bisa nih improve ourselves gitu. Jadi kita naik level dikit lah. Kita nggak hanya ingin fokus ke awareness, tapi kita akan lebih advance untuk ke beberapa hal, termasuk kegiatan penelitian. Jadi di 2021 ada beberapa tim yang kita bentuk. Yang pertama adalah awareness, itu masih ada. Nanti teman-teman ikutin aja Instagram dan Facebook kami, karena nanti akan ada event di tanggal 29 Mei, nanti informasinya akan kami sharing di situ. Kemudian di tim research kami mencoba untuk melakukan penelitian multi-center di beberapa wilayah di Indonesia, nanti kerjasama dengan PPIAI. Kemudian di AMR tuberkulosis, ini kerjasama dengan Hisparkesmas, Himpunan Farmasi Kesehatan Masyarakat. Nanti kami rencananya akan membuat event khusus tentang tuberkulosis. Kemudian di Focus on Environmental Health, kita akan mencoba membuat gerakan atau movement dalam rangka WPD, World Pharmacy Day bulan September. Nanti kerjasama juga dengan beberapa pihak, termasuk kami sedang coba approach ke UN Environment Program, jadi agar ada insight tentang kesehatan lingkungan dan dampaknya terhadap AMR. Dampak AMR terhadap kesehatan lingkungan. Jadi nanti kita akan belajar banyak di situ. Di AMR vaksin ini masih akan di-create. Jadi karena sekarang vaksin COVID-19 juga masih up down dan COVID-19 juga masih banyak PR-nya. Kami harap teman-teman masih tetap semangat ya belajar walaupun secara daring dan dengan tantangan di tempat praktek masing-masing gitu. Semoga kita semua sehat selalu. Kemudian di regulatori kita berfokus pada kebijakan-kebijakan AMR di Indonesia. Dan yang terakhir ini edukasi on sosial media. Di sini ada 3 orang tim kami. Yang pertama Kak Nadia, PIC-nya, kemudian ada Kak Sheila dan Kak Debbie. Ini mungkin yang agak masif kegiatannya karena ada beberapa event di Instagram dan Facebook dan YouTube. Jadi mungkin demikian Kak Kevin perkenalannya, silahkan dilanjutkan. Terima kasih Kak.
Terima kasih Fitria. So Prof. Leda, earlier on, Fitria mentioned about the different kind of areas where APA is actually moving around: awareness, research, AMR tuberculosis, and focus on environmental health, vaccines, regulatory and education, social media. So it started off with the initiative where they were celebrating World Antimicrobial Awareness Week in 2019, and then right now they are moving on 2 years, and then they're getting the movement, stronger and stronger in hope to actually educate more pharmacists and empower more pharmacists in Indonesia. Yep.
Okay. All right, great.
Yep. So okay, so teman-teman sekalian, so friends, actually hari ini kita sangat senang sekali karena bisa mendapatkan satu speaker dari Samford ya. Samford University itu di Alabama, dan itu kalau kita dari Jakarta pergi ke Samford ke US itu perlu 25 juta ya. 25 juta dan sehari lebih untuk terbang ke sana. So itu beneran satu great honor ya. It's a great honor for us to have you, Prof. Leda. That we need to travel all the way to US in order to see you. If let's say we to see you physically, it will cost us around 2,000 USD to just see you. But now we can do it virtually. So it's a really great honor for us ya teman-teman. Jadi ini tuh sangat spesial sekali event hari ini ya. Terus saya memperkenalkan Prof. Lender. Jadi Prof. Lender adalah profesor di Samford University di Birmingham, Alabama. Terus sekolahnya namanya School of Pharmacy. Jadi mereka kan ada universitas, terus di fakultasnya namanya McWhorter School of Pharmacy. Terus dia Prof. Lender di Department of Pharmacy Practice-nya. Sejak tiba di McWhorter School of Pharmacy di 1986, Prof. Lender juga telah bekerja keras untuk membuat perubahan. Dia datang ke sini karena mau lebih terlibat dalam pendidikan farmasi dan mengembangkan program penelitian di Fakultas Farmasi. Dia bekerja di pusat farmakokinetik sekolah selama 3 tahun, tapi kemudian balik ke praktek farmasi. Dia telah membantu keterlibatan internasional di sekolah farmasi, termasuk rotasi siswi di Inggris, Indonesia, dan Vietnam, serta menawarkan kesempatan belajar atau pelatihan di Universitas Samford untuk apoteker asing. Selama waktu luangnya dia menikmati pekerjaan kayu, gitu ya. Dia suka woodwork panggilnya ya, bikin produk-produk yang terbuat dari kayu. Nah, ini adalah data-data Prof. Lender ya. Prof. Lender Pharm.D di University of Missouri, terus dia Bachelor of Pharmacy di University of Missouri juga. Terus Prof. Lender juga member dari American Society of Health System Pharmacists. Dia juga masuk ke College of Clinical Pharmacists dan Board of Pharmaceutical Specialties. Itu Board of Pharmaceutical Specialties yang kita omong kalau Prof. Lender, jadi dia spesialisasinya sebagai apoteker. Jadi kalau misalnya di Indonesia kan dokter bisa spesialisasi, kalau di US Prof. Lender juga ada spesialisasi dan dia fokusnya ke ambulatory care gitu. So kita lihat di sini ekspertisnya ambulatory care, health outcomes in underserved populations, pharmacokinetics, smoking cessation, dan diabetes management. Terus ini adalah award dan honor yang telah didapatkan oleh Prof. Lender. Dia mendapatkan School of Pharmacy Teacher of the Year pada 1994. Terus Who's Who Chair Award Pharmacy Practice Section di American Association of College of Pharmacy. terus involvementnya Prof. Lander, dia juga involvement di American College of Clinical Pharmacy. Terus Prof. Lander adalah salah satu yang menemukan Asian College of Clinical Pharmacy, ya. Terus American Society of Health System Pharmacies, American Pharmacists Association, dan Dawson Baptist Church, itu aktivitas Prof. Ya. So that's my introduction of you, Prof. And maybe I'll pass on the floor to you so that you could do a bit of sharing about your life as a pharmacist in the US, and all about your practice, and how you've been empowering people. After that, I'll do a bit of translation in case some of my peers are not able to completely catch it. So sorry about that. Yep. Please go ahead, Prof.
Well, that's good. Thank you very much for the introduction, and thank you for the invitation to do this. Let's see here. If I...
Pak Kevin, mungkin Prof. Lander akan sharing slide, jadi dibuatkan co-host.
Yeah.
Okay, let me make you a co-host so that you can share the screen. Okay, please go.
Here we go. Here we go. So can you all see that then, that the first slide? So I'll change this to the slideshow here. So as you mentioned, and it's actually been 40 years ago this year that I got my Doctor of Pharmacy degree, and I started out working in the hospital, and then I actually became the chair or head of my department in the School of Pharmacy. So I was an administrator for about 7 or 8 years. And then I became an ambulatory care practitioner and started working at the local, in the US, we have the local county health department, which actually takes care of patients in the United States that do not have insurance. And so they typically come and get public healthcare assistance. And so I practiced there for about 16 years with a physician and a nurse practitioner and myself. So, and that's actually where I have done smoking cessation and diabetes management, as well as just generally seeing outpatient adults with a variety of different problems. And when Fitria asked me to do this presentation, I thought it was kind of interesting because my very first teaching responsibility was to teach antibiotic therapy to medical students. And so that was actually the first set of lectures, group of lectures that I gave as a new faculty member in 1982. So it's been quite some time ago. And so antibiotics have always been an interest of mine. And of course, resistance, although I would say in the last 20 years, it's become a much more highly discussed topic. It obviously has always been a problem. In fact, a lot of the things we would read and that, would tell us that even before we as practitioners and scientists had discovered antimicrobial agents, bacteria and fungi and other microbial agents had already developed resistance to the antibiotic chemicals that were in the soil and the water and the ocean and various plants and that sort of thing. So it's a very long-term problem, but it is really in the interest in a medicine and healthcare in recent years is because it does seem to be speeding up. It is becoming much more quickly. Bugs are becoming resistant to the antibiotics that we have to work with. And so I'm going to spend a little bit, I don't have too many slides, but I just wanted to kind of give a bit of some background because I didn't really know where all of you are kind of in your training and development in this particular subject. And then I hope we can have some time to spend discussing things, and I can try to answer some questions. I am certainly, I have a good bit of knowledge in this area, but I would say that I am not an expert. So, you know, I will try to help you if you need to try to find more information. And of course, there's all the way from the very bottom level up to the very specific kind of level of different antibiotics and their mechanisms that bugs use to become resistant. And I think the thing that I would tell you is, in the period of time that I've been a pharmacist, and so many of you, or most of you hopefully, are much younger than I am, and the time that you will be a pharmacist, it will rapidly change the things that we know about antimicrobial resistance. And so I'm going to go on, and before I leave this slide has my email on it. I will send a copy of these to Kevin and Fitria perhaps after we get done, so that they can distribute these to the rest of you and that kind of thing. So, so don't worry about that. But my email address is there. Feel free to email me if you have a question or something in the future, or you have you're seeing a patient and they're very difficult and you would like a sort of a second opinion about that case and what you might be able to do. I love helping other pharmacists develop their skills and that kind of thing. So don't be afraid at all of sending me an email and asking me a question in the future. So first off, I wanted to just kind of state what the problem is. And this is sort of, we know that for decades, antibiotics and antifungals, antivirals now more recently have been used to treat infectious diseases. And as I mentioned, though, the organisms are able to develop resistance, and they do that through a number of ways that we'll talk about. And just to give some background here, and Fitria mentioned that you all had a presentation from the WHO, and some of these stats are actually from the World Health Organization or the CDC. And this, in the US in 2015, they calculated that there were probably about 23,000 deaths from antimicrobial resistant infections, essentially that we could not successfully treat because the infecting organism was resistant to all of the various antibiotics that we have on the market and available to use. And similarly, there's an example here in Europe about the same thing, 25,000 deaths due to antibiotic resistant infections. And it mentions here, and this is kind of an interesting thing to me, again, because I've been in practice so long. When I first started practicing, you'll see on this slide, it says that today, 7% of all Candida fungi are resistant to fluconazole. Well, of course, the azole antibiotics were not even on the market in the United States when I became a pharmacist. But also, when they did become available, there was absolutely no resistance to them by the fungi Candida. And now we see that 1 out of every 14 cases is resistant. And so that can be a real issue for us. So so this is just kind of a background that shows us that. And so other thing here in Asia, in the Mekong Delta, signs of malaria not only being resistant to one of the older original medications, but being resistant to all of the anti-malarial drugs. And so patients, again, it's been roughly 100 years that the cause of malaria in humans was even discovered. How did it get from how did the organism infect human people? Was discovered in the early 1900s. And now And of course, we've been able in many cases, if we could get medication to the patient, we were able to treat that effectively. Now we're to the point where we've got malarial organisms that actually won't respond to medication that we have. And so that's a real problem. And, you know, in the 1980s and 1990s, when I practiced, it was very unusual for us to have a patient come in the hospital with an infection and us not have something that was going to cure that infection and fix that problem. But now, of course, in the last 20 to 25 years, we've seen the rapid growth in that. And part of that, and the point that I put this on the slide for was that we used to think that really the primary thing that caused this resistant problem was the overuse or misuse of the antibiotics that we were giving to patients during their infection. We now realize biologically, generically, that it's much broader than that. There are many, many more problems that create antimicrobial resistance in humans. And misuse of antibiotics is certainly one of them. And that's a place where the pharmacists like you all forming this group can have an impact on that by advising people on what is being used. But as we'll talk about, it's a much deeper problem. And the fact that for many years we did not know that was an issue. You know, in the US, we say, if you don't know what the problem is, you can't solve the problem. And so this is an example of that, where until just recently, we didn't really understand how many different things contributed to this resistance problem. And now we understand it much better. And so we're making some good strides at trying to fix it, trying to address the resistance problems. But unfortunately, especially with antibiotic development, the number and variety of organisms that are developing resistance is still moving faster than our development of new antibiotics to be able to treat them. And so even from that more narrow perspective, it's a very dangerous problem. It really is a difficult situation. So let's take a look at some of this. And so I like to just kind of do this to point out in this slide that, you know, we are the host, the human host of infection. But remember, we're not the only mammal or animal or insect or, you know, things on the earth that host infections. We're the most complex one, certainly, and that's part of the issue here, but we're not the only one. And so all of these four things in the outer circle affect the resistance pattern in the middle. And so we have us as human beings. We have on the right there the organisms themselves. And of course, we're realizing more and more how complex those organisms are, how much more they do and have capability to do than what we've ever understood before. So, and then the environment, and this is important, and we'll talk about that a little more in a minute. And then the treatment itself. And so this one on the left is really describing the interaction, how the treatment of infections leads to resistance. If we use too broad a spectrum of an antibiotic and it affects the resistance patterns of other organisms or bacteria in our body, then it creates more problems. And so as pharmacists, of course, that's one of the primary things that we can do to try to impact the development of resistance. But we can also do things about all these other three things. in this slide as well. So we want to remember that. And so the next slide really focuses on the host part of that. And so if we look at the previous slide, the host was up here at the top. And so now we're kind of looking at that host as one of the four things here. And so we've got our immunity. And for a long time as a pharmacist, I didn't realize this, but much immunity, and especially the way that we react to anti-infective agents, antimicrobial agents, is developed by our immunity even when our mothers, before they delivered us, while our mother was pregnant with us, that impacts the immunity of the baby. And what kinds of, because if you think of that, then the other thing here is down at the bottom, the colonization of the host. And so if you think of a newborn baby, they have billions and billions of bacteria on their body, in their lungs, in their airway, in their mouth, in their colon. And so they already have bacteria that when it gets exposed to different things will either develop resistance or it will remain affected by an antimicrobial agent. And then the infector itself, as the infection interacts with the human host, it can develop more resistance. And how does it do that? Well, you all probably know the term and understand plasmid-mediated resistance. Plasmid is a protein cap or polymer substance that gets encapsulated and moves from one bacteria to another. And so if you have a bacteria in your body that is sensitive to, or maybe is resistant to a particular antibiotic, that bacteria can share its plasmid with the infecting different bacteria and make that infecting bacteria become resistant to the antibiotic. And so this interaction of these different bacteria. And I wanted to mention something here that y'all, I don't know if anyone else has read this or not, but did you know that the human body contains 300 times the diversity and variability in bacteria than what there is any place else in the environment? Like in the dirt, in the soil, in the ocean water. We have more types of bacteria on us than you could find in any other human or any other animal or any other substance basically on the earth. So like our GI tract, the lower part of our GI tract, the colon, has more different types of bacteria than almost any place else in the world. And so we can transmit those like through plasmids and other mechanisms to the infecting organism that tries to infect us as the host. And so that's a major way that those infecting bacteria become resistant to the antibiotics and different antimicrobials that we have. So that's, so that's an example in us as the human host kind of thing. And then what about the organism? Well, the organism, it can develop resistance different ways, right? And we just talked about the host interaction with the organism. So our body and our bacteria and that kind of thing. What about the adaptation ability of that organism? It can change over time. So it basically, it's smarter than we used to think it is, right? It can make new resistant proteins, or it can change its structure, its cell wall structure or cell membrane structure. It can create more proteins that are enzymes that destroy the antimicrobials that we give to the patient. And so that is an organism adapting to things. It also, yeah, sorry.
No problem. I think there was an accidental,
Okay.
yeah, okay.
All right. So, and then the next thing is other parts of the environment down at the bottom. And so that organism, it not only can interact with us and gain resistance factors, it can interact with other things in its environment, like the soil or the water, right? And, you know, again, like when I first became a pharmacist, we didn't even think about this kind of thing. But when you dump the antibiotics down the drain in your hospital and it goes into the water supply, then those antibiotics are going to change the resistance characteristics of the microbes that grow in that water. And when that water is used to irrigate the land around your hospital and gets in the soil, then it's going to induce resistance in the organisms that are living in the soil. And maybe they haven't ever been an infector of human beings before. But just like the COVID virus that we've all faced this last year, it comes along and something changed it to make it want to infect human beings, right? And so it became a worldwide pandemic. And it obviously it became a pandemic because we didn't have an antimicrobial agent to treat it, right? And it took several months to develop a vaccine, right? So it's, you know, so that virus is a great example of something in the environment changed that virus and made it become a coupling to a human host as an infectious agent, right? So things like that. And then the exposure during the treatment, obviously, again, when we give the patient antimicrobials, you all know about selective pressure of antimicrobial treatment. That selective pressure kills the bacteria that are sensitive to it, and the ones that are resistant then begin to grow and multiply, and they become the major population. And so that creates a pool of organisms then that can infect people and be resistant to the antibiotics that we have. So all of those things can contribute to the resistance of the host. Now here are things that affect the treatment. And we often think of the resistance mechanism up here at the top. And so we do a culture in the patient. We get the culture back and it tells us antibiotic A, B, and C, the organism is sensitive to it. Organism or antibiotics D, E, and F, the organism is resistant. So of course that helps us because that tells us don't use antibiotics D, E, and F, correct? We're going to use antibiotics A, B, and C that are sensitive. But when we use A, B, and C, what do those do to not only that organism, but what do those do to the billions of other organisms that we have in our body, right? And so we know like C. diff diarrhea, for example, is a result of killing off the good bacteria in the colon and leaving C. diff that is resistant to whatever antimicrobial agent we're giving to the patient at the time, right? And so the patient overgrows that bacteria. So that's an example of selection and in some ways resistance, because that C. difficile that we have nowadays in a hospital, again, 30 years ago and 40 years ago when I first started practicing, it could be treated just like that. No problem, never a problem. You know, anybody who got C. diff diarrhea could easily be treated. Nowadays, we've got resistant C. diff, you know, and it's caused by bacteria that reproduce because we give an antibiotic that it's resistant to start with, and then it's resistant to our normal treatment for it. So it's like a double effect kind of thing, you know. So that kind of thing. The volume of use, of course, again, this is an area that you as pharmacists hope to impact in your practice directly and indirectly. You know, what we're doing tonight is hoping to educate and raise the discussion among pharmacists on what pharmacists can do to these situations, the volume of use. What can we do to the environmental impact? You know, should we be dumping the excess antibiotic IVs down the drain and ruining the water supply? Is there another way to get rid of them? You know, is there a better way to do that so that we reduce the impact on the environment? Host non-compliance. Of course, this has always been a problem, because if the patient doesn't take the antibiotic like they're supposed to, then that's just going to make the resistance development worse, right? So we all know about this one. So this educating the patient and the other healthcare workers, this is again a role for the pharmacist, very important, that we try to impress upon people. You take all of your antibiotic, you know, but to the prescriber, the pharmacist or physician or nurse who prescribes the antibiotic, we want them to don't give too much. You know, don't just put somebody on a month's worth. They may not need that. So we become more specific as we go along and we learn more about how long does it take to treat this particular organism. Because if we give more or the patient doesn't take it every day, then that just raises the likelihood of resistance kind of thing. And then obviously the breadth of exposure. So here I'm talking about not only the number of people that get treated from the volume over here, but the breadth. What kind of antibiotic? And so this is, and of course, nowadays we use a lot of very broad spectrum agents because we're trying to treat many times an unknown bacteria. 100 years ago, when somebody developed a sore throat, you could almost be sure that it was streptococci if it looked a certain way on physical exam. Nowadays, it could be 5 or 6 different organisms, right? And so our reaction to that changing infection thing is to use an antibiotic that will kill any of those 5 or 6, right? But in doing that, then we're exposing the environment and the host and everybody to that broader spectrum antibiotic and causing more resistance. And this is actually something I'll mention now, is that one of the things that is becoming, and I don't know about there in Indonesia, I would presume that probably not yet in most places, because this is still even very uncommon in the United States. But instead of doing the typical like culture and sensitivity on the organism, actually doing genetic typing and coding on the organism. And so we could swab the person's throat, and instead of putting it on a culture plate and trying to grow it, we could send it to the genetic typing lab and find out within a few minutes what that organism's resistance patterns were based on its genetic makeup, right? And that I know of in the US, that's typically only being done in like research purposes and labs still. But with the increasing knowledge and ability and machinery to do genetic testing, I expect that it will not be that many more years before that becomes the standard way to identify the infecting agent rather than using a culture plate that we've been doing for, gosh, 130, 40 years now, right? So that technology is going to help us be able to make decisions on the treatment, which treatment to give more quickly. All right. So, and then here's the environmental perspective. And one of the things, Kevin mentioned my education. I grew up in Missouri. And if you all look at a map of the United States, if you look up the state of Missouri, the state straight to the south of Missouri is Arkansas. And I was actually born in a little town in northern Arkansas. And the thing that's interesting about that area of the US is agriculture. It's actually known as you all know what a turkey is, right? Bird that we eat. We eat them on Thanksgiving here in the United States. Where I was born is the turkey capital of the United States. More turkeys raised there than anywhere else in the US, right? And turkeys specifically, they put antimicrobial agents in the food that they give to turkeys to keep them from getting sick and to make them have more meat on them, to get bigger, right? And so that exposure of that animal to antibiotics is increasing the microbial resistance in the environment in that area of the country. And of course, in the US, the company that processes turkeys sends turkey meat all over the United States. Every grocery store has the meat there. So we eat that meat as a human, and it's got antibiotic in it, and it changes the flora, the microflora in our body. So then if I get a real infection, I go to the hospital, I'm more likely to have an antimicrobial resistance because of the turkey I ate, because the turkey was given antibiotics, okay? So, and I'm sure that's actually probably common in your country as well. It's not uncommon really all around the world for food animals that are used for food to be given antimicrobial agents to help them. So, and that used to be done, we didn't even know it, okay? It wasn't until maybe 30 years ago that we started discovering, oh, you're doing what on the farm? You're putting antibiotics in the food for animals that then we turn around and eat, you know, in the United States. So, so that kind of thing. So the environment is affected by all of these. The other thing people are really beginning to wonder, and I really don't know much about this, but of course, and it reminds me again of the COVID story that, and you all probably heard this too, that COVID was either going to become better or worse during the summertime when the weather got warmer, right? And of course, we were all talking about the globe getting warmer, global warming. And so what effect does that have on the antimicrobial resistance of different organisms? I'm not sure, but it certainly, the environment and the climate does have an effect on that pattern kind of thing. And then I just put animals here because animals and agriculture, of course, is a broader term and would include even things like growing vegetables, right? Vegetables get infected with different kinds of organisms as well. And so sometimes in growing vegetables, they are actually treated with antifungals and antibacterials, right? And so again, that's a source of resistance in the patient. All right, now I wanted to show you this, and this may be, this may not translate very well, Fitria, but okay. But this is a PubMed search for antimicrobial resistance up here toward the top, right? And you see from 1945 to 2021, there were over 300,000 papers published on antimicrobial resistance. So it's a big topic, okay, big area, right? Now my next slide, I trimmed that down to the last 5 years, okay? And there were still over 39,000 papers published on antimicrobial resistance just in the last 5 years, okay? And these are not all of them. These are the ones that are available full text online, okay? So again, I put those in there just kind of for fun to give you an idea of how big the problem is, how large of a topic this is. All right. So antimicrobial resistance is a global concern. And we as clinicians in patient care areas, we typically have been the ones that have kind of been the most concerned about this. And we also have sort of been the ones who have sort of led the practice to try to have an effect on reducing this, right? And so, and that's good. There's no problem with that. The only difficulty is that, as this letter B says, we're realizing now that the problem is much bigger than just hospital infections or human infections. It involves the environment, the climate, the bacteria themselves, the fungi themselves, you know, and the what we'd call the human biome, essentially, or the human microbiome. So there are a lot of different things that affect this, right? So, and then this letter D is kind of the one that we've known about the longest. This is the selection pressure, the effect of giving broad spectrum antibiotics on increasing resistance. But it's also compounded by the transmission of bacteria and other microbes from person to person. And those like plasmids, for example, transferring bacteria that carry resistant plasmids to beta-lactams or clindamycin or quinolones or you know, a host of different antimicrobials, those being transferred directly from person to person. Doesn't really take a hospitalization to do that. It just happens naturally in the environment. And so we have to be concerned about that. And these ones, this is letter F is a real interesting one. If we put this together, this says that microorganisms that affect the human body are of particular importance in antimicrobial resistance. Well, several minutes ago when I first started presenting, I told you that the human microbiome has 300 times the number of different kind of bacteria as what you can find anywhere else. And so the fact that that's true and that the human microbiome is the main thing that's responsible for this, it's our own bodies, you know, it's people to people causing this, not, you know, so much other organisms or plants, although those of course are important too. So it's all of that. So, and then because, for instance, children are exposed to this changing human microbiome earlier in life, it becomes a problem over a longer term. And because they have those organisms on them or inside them, the natural selection and resistance development by those organisms has longer to take place, right? And so it becomes more complex than what it was 10 or 20 years ago, right? And so it's, you know, it's a kind of a very difficult spiral, continuing, getting worse and worse kind of thing. So, and this, as the last one says, that basically means this is going to get worse. It's going to be exacerbated before it gets better, because we're really behind on trying to develop new antimicrobial agents, especially with bacteria. We're doing better with the more unusual things like the viruses. Okay, and oh, was that? I don't think that was it. I'm sorry, excuse me, let me go. Yes, that was it. That's my last slide. Okay.
Thank you, Prof. Thank you so much. Yeah, so maybe I'll do a quick summary to my peers about this. Oke, teman-teman. Jadi ini ada presentasi dari Prof. Lender. Jadi dari Prof. Lender tadi dia sudah mengutarakan bahwa ya EMR itu sangat problem yang sangat besar. Dan kemarin kita juga ada event WHO dengan Indonesia yang dengan Asian Young Pharmacist Group dan IPSFA Pro. Itu kita juga dari WHO juga mengutarakan adalah problem-problem ini. Dan bisa kita lihat proses AMR ya, AMR itu bukan proses mekanisme yang sangat simpel juga. Itu salah satu yang paling besar, faktor yang paling besar adalah manusia. Manusia itu menggunakan antibiotik untuk makanan, untuk binatang, asal menggunakan, asal membuang. Nah, terus dari manusia ini, manusia adalah satu kompilasi bakteri. Di badan kita banyak mikrobakteria. Jadi kalau ada bakteria masuk ke mereka masuk ke kita, mereka mungkin yang resistensi mungkin terjadi karena mereka masuk ke badan kita dan mereka transfer ke tempat lain. Dan menurut Prof. Lender, di badan manusia adalah kemungkinan untuk bakteri mendapatkan resistensi adalah paling tinggi ya di badan manusia. Dan itu kalau kita lihat kita makan barang dan kita proses-proses yang lain itu juga bisa menyebabkan resistensi. Nah, ujung-ujungnya EMR itu sangat problem yang sangat besar. Nah, ke depannya kita juga harus hati-hati. Nah, begitu saja ya untuk itu untuk segi besarnya gitu. Dan thank you, Prof. Lender. We have some question right now. We already have one question from for you. Okay, it's coming from Kartika Citra Dewi Permatasari. Prof. Lender, thank you for your great presentation. I wonder about your opinion about how big the effect of people's belief about antibiotic drugs causing their attitude of antibiotic usage. I see the phenomenon instead of their knowledge regarding antibiotic resistance. Some people still feel safer using antibiotic than waiting it to be proven as infection problem.
Yeah, and so that really is an issue, and especially and again, like and of course this we have here in the U.S. there are very limited number of antibiotic, like either ointments or solutions and things that people can buy without a prescription. But I know in many Asian countries, antibiotics are available either directly from the pharmacy or over the counter in even non-pharmacy stores like grocery store or that kind of thing. And so and that is a problem. I'm reminded actually of, just quickly, when the first time I went to Vietnam, the WHO representative in Vietnam wished to speak with me. So they took me to meet with her, and she was very concerned with the TB resistance, because patients could buy antibiotics over the counter for upper respiratory infection, and they would treat it 2 or 3 different times, like take 10 days worth and then stop. They would feel better. And then over a month or 2, they would get worse again. And then they would go get a different antibiotic and take treatment. And then they would find out later, 3, 4, 6 months later, that they actually had pulmonary tuberculosis was what their problem was. And then go to, hospital and get good treatment, good effective treatment. And of course, all that time, those other antibiotics like quinolones and things that are used for resistant tuberculosis in some cases, the patient was being exposed to that already. So that's how they develop the resistance. So that is a problem in many parts of the world. And of course, the whole, if I'm coughing, I must need an antibiotic, right? Because I have an infection, right? Wrong. No. Right. So I'm not infected. As a patient, I don't need to make the decision that I go take an antibiotic. So those are both very significant problems. That's why it's so important. I love that you all are doing this in your country, because it's so important for the pharmacist to educate the public that, that kind of thing, an antibacterial drug will not do you any good to treat, your upper respiratory viral infection that you most likely have. There isn't anything to treat it. You just have to wait it out and wait till it's better, And so the public education of that is really important, but especially with things now, again, the difference is like when our parents were children and they went somewhere and they got a dose of oral penicillin, it was so narrow spectrum that it didn't really produce the resistance problems that we now get when we take cephalosporins or tetracyclines or fluoroquinolones. They're much worse in that respect. And so that environmental resistance spread by that is a real issue. So that's really something you can try to have an effect on, even if you can, now, the physician I worked with here in Birmingham, her husband was related to the Minister of Health for the country of Vietnam. So we were able to go in and talk directly to the Minister of Health to try to get an effect on the OTC use of antibiotics. But it didn't help very much because they still sold them over the counter, right? But just raising that issue, like with World Health people and public health departments and the government, ministries of health and that kind of thing, can be really important. And the thing to realize, and I don't want to go on too long about this, but the thing to realize is that those people, they're very smart, okay? Like the Minister of Health, he was a very knowledgeable man, but he's too busy to keep up with the science of the area of antimicrobial resistance. So he needs to be talked to by people like you that know what you're talking about and can give him information to try to influence, the government's role in those kinds of decisions, how we're going to use antibiotics in the larger sense. So.
Thank you, Prof. Lander. Thank you so much. A
lot of the other thing is I mentioned like the creams, like, somebody you put in their note, polymyxin and pediatric wards and things. Just most of the time, don't do it. I mean, using an antiseptic like alcohol or something like that is enough. Don't try to convince people that they don't have to expose the patient to those kinds of things, because even topical polymyxin, if the skin, for instance, is not broken, there's really no reason to use it. And if the skin is broken, it's going to get in the body and cause bacterial resistance when you put it on the person. So, and so they're very overused in most populations. Now, I won't say that all the time, that there's not a use for them. I don't want to misunderstand me, but much of the time they're way overused. And even in the US, I've noticed in the last 4 or 5 years, seems like there's a real public fascination with ointments and creams, antibiotic ointments and antiviral ointments and things like that. And they're not very effective to begin with. So is there a chance for different classes? Yeah, there is, especially among cephalosporins, because, for instance, the 2 drugs you've got here listed, ceftriaxone and cefotaxime, they're sensitive to different beta-lactamases. And when we get into some of the organisms that are causing infections nowadays, sometimes, not always, sometimes it will be a fairly wide class effect, but sometimes the organism, one of the things we've figured out in the last, I don't know, decade or so, and you probably heard of this, is the organism actually pumps the antibiotic back out of the cell, right? And it will do that with only certain specific, like cephalosporins, and not do it with all 3rd generation cephalosporins. It's not the same. And so, and, I'd be glad to, come back again, in a few months or something and talk about some of those specific kinds of things like that, if y'all want to do that. I sort of, I wasn't sure to go specifically into areas like that, but that's a great question, because, the difference between levofloxacin and ciprofloxacin, they're not the same, and so that's a really good point there, and part of that's actually cefotaxime, for instance, has been on the market for 30-something years, and ceftriaxone, at least in the US, about 10 or 12 years less than that. And so ceftriaxone will still treat some things that are resistant to cefotaxime, but it's also different organisms. So one will work better than another one, that kind of thing. But yeah, I hope that answered your question.
Ya, thank you Prof. Lander. Jadi teman-teman, tadi kan ada komen dari Prof. Lander. Kalau misalnya bakterinya simple dan atau pasien dia cuma batuk biasa, tidak perlu direkomendasi antibiotik karena itu mungkin viral infection. Kalau viral infection pakai antibiotik nggak ada guna. So I was sharing about what you shared earlier on, Prof. Lander, that if let's say patient have URTI, they don't necessarily need antibiotics. Maybe it's just a viral infection because virus don't respond to antibiotics. It's no use basically, right? Right. Terus Prof. Lander juga bilang jangan pakai polymyxin. Ya, sesimpel mungkin kita pakai targeted therapy ya. Kalau pasien bisa recover sendiri. Terus Prof. Lander, we have one question regarding livestock here, the environment. And you were saying about, Turkey from your hometown. Right. Okay, the question is, Prof. Lander, how is the way for the government in the US to control the antibiotic usage in livestock? What kind of regulation is made to prevent this, or maybe to control this? Yeah.
So again, that's a great question. And so in the United States, they really have done a few different things at different levels of government to try to get a better control on the use of antimicrobials, say in animals like this, in food animals, cows, sheep, turkeys, chickens, that kind of thing. And so publicly, the sort of nutritional folks in terms of agriculture and nutrition are trying to push the idea of healthy food. And so, and it's really a campaign, a sort of an advertising campaign to get people, and one of the words is organic food, right? And so like organic vegetables means vegetables that are grown without the use of insecticides or herbicides or antifungal agents or that kind of thing. And so they're trying to tell people in a sort of a way is that this is probably better for your health. So pick out some of these when you go to the grocery store. And then they actually have, in cases where we have documented the effect on microbial resistance of like the turkey example that I used, the government is actually at both the federal and the state level agriculture departments have tried to decrease, maybe not completely eliminate, but to decrease the concentration of the antimicrobials in the animal's food. So to lower the exposure, and in some cases completely actually ban it, like eliminate it, make it, you know, not okay to do kind of thing. So yeah, that's another great question. Yeah. And some of that again is because of health professionals like physicians and pharmacists and microbiologists becoming involved in talking with government people. And again, like when I first became a pharmacist, I never really thought of that as a part of what I needed to do, you know, kind of thing. But nowadays we're teaching our pharmacists and medical students and things, it's having an impact on human disease. So we all have to work to try to affect what is being done in those cases. So.
Ya, dari Prof. Lender juga ada mengutarakan bahwa apabila kita kan sudah mulai teredukasi. Nah, kalau kita teredukasi, kita harus sering komunikasi dengan Kemenkes, dengan orang-orang sekitar kita juga kita, ya. Jadi kita harus mengutarakan lah ya, kalau misalnya ada masalah ini. Dan jadi lebih banyak orang aware, nanti mereka juga akan lebih ada movement-nya gitu ya. Okay. Prof, one more question we have. This is actually a common scenario in Indonesia from Ilil Zulfa. So, Prof, he or she is asking that in the US, do you still have a lot of requests for antibiotic without prescription? What is the strategy of the pharmacists there to handle and educate people?
Yeah, so if I understood you right about the availability of antibiotics.
Yep,
yeah,
without
prescription.
Off the counter,
yeah.
Without prescription.
So it's really pretty limited. There are really, I can't think of any oral antibiotics that are available without prescription. So really the only ones are like topical creams or that kind of thing. There used to be some oral rinses, mouthwash kind of things that had some antibiotics in them, but they pretty much are not now. So the topical ones are the main ones. And those only the general topical. In other words, like the creams and ointments for the eye or for ear infections, those are all prescriptions. Those all require a prescription as well. So, so that it's and I think that helps us compared to a lot of other countries that have OTC antibiotics available. I really think the broader effect on public health, it would be good if all countries required the patient to receive a prescription for antibiotics. Now, I would be in favor of, in some instances, pharmacists being able to prescribe those antibiotics. But of course, they would need to be educated on the practice of how to do that. And then, and that's not done in most places in the US. Some drugs are available on the advice of a pharmacist only, but it usually is not antimicrobials. But there are some instances where a pharmacist will have essentially work out with a physician the authority for the pharmacist to directly prescribe things for the patient. So, and that's the most common thing right now in terms of infection is actually vaccines, for instance. So pharmacists can provide like influenza, pneumococcal vaccine. And of course, we're part of one of the groups that can essentially order and administer COVID vaccine to patients. So that's, the federal government did that because of the need for large numbers of being able to vaccinate people. So
thank you so much for the wonderful sharing, Prof. Lander. And yeah, I guess we could maybe possibly take one last question. Ada satu pertanyaan terakhir dari teman-teman sebelum kita selesaikan.
Boleh Kevin, Kak Kevin, saya boleh bertanya?
Okay, Fitria has a question.
But I wanna ask question in Indonesia. Sorry, sir. Maybe Kevin can help.
Yeah, I'll translate. Yeah.
Jadi begini, Prof. Lander tadi kan sangat menarik tuh penjelasan tentang One Health approach, di mana sudah banyak nih yang aware atau memperhatikan hal tersebut. Apakah ada saran, Prof, untuk membuat semacam rencana aksi nasional di Indonesia gitu, sehingga tidak hanya apoteker yang aware, tapi juga nakes lain termasuk dokter, perawat, dan juga masyarakat pun aware agar mulai bijak nih menggunakan antimikroba. Demikian, Prof. Terima kasih. Thanks, Kak.
Okay, Prof. So the question from Fitria was related to about the interprofessional health, One Health approach on antimicrobial. So it seems that such approach has already been implemented in the US. But what would be a recommendation for countries such as Indonesia?
Yeah, so if you're in any type of system, either a hospital or like an elderly care setting, try to develop a team with the pharmacist, a physician, and usually in the US, in the hospital, it will be an infectious disease specialist physician. And then oftentimes we have what are called infection control. It's usually a nurse, and they look at resistant infections. And so that the nurse often has been doing that before, but start a team where you sit down and review those patient cases together. And then what we do in the US is we have pharmacy and therapeutics committees in the hospital that make policies for the drug utilization in the hospital. And usually the P&T committee will approve this antimicrobial stewardship program. And when they do that, then they essentially make policies where the people prescribing the antibiotics, the physicians generally, will have to follow the recommendation of this stewardship team. And so somebody mentioned the patient on 3 antibacterials when they just had a respiratory viral infection. You know, if you had a situation like that, it's not usually in a hospital, but if they were in a hospital, then this antimicrobial stewardship team would basically have the authority to tell that prescribing doctor, you need to stop all of the antibacterials and give the patient antihistamine, decongestant, and fluid, you know, for the treatment kind of thing. So, and those teams are still not common in outpatients in US, but it is beginning to happen. There are some. So, you know, we have lots of very large outpatient clinics here that many physicians, and get the other person in that case that's important is if all the doctors send the cultures to a specific lab, get the microbiologist from the lab involved with that team. So ID, microbiology, pharmacist, nurse, work as a team together. And that's antimicrobial stewardship teams has been one of the very good examples of interprofessional practice in the United States among the different disciplines. So, and that's, you know, sometimes the pharmacist can do it by themselves, but a lot of times it's accepted by the physicians better if it's a team, if it's a group, you know. So, and I'm reminded of the very first time I went to Cipto Hospital in Jakarta. I went to the neonatal ICU with the pharmacist, and there was a neonatologist physician who worked there who had trained for about 6 months in the United States. And she said, Prof. Lander, I have a question. She said, we have a very high infection rate in our neonatal ICU. She said about 70% of the newborns get infected. And she said, is that high? And I said, well, I'm not a neonatologist. I don't take care of babies, but I said, that sounds very high to me. And so I asked them how they were making the medicines. And she said, well, the nurse is mixing the IV drugs here on the table in the intensive care unit. And so I had the pharmacist with me, and I asked the pharmacist, could the pharmacy make those drugs in a hood, sterile hood in the pharmacy? And she said, oh yeah, we have a sterile hood downstairs. So I turned and asked the neonatologist, would it be okay if you tried to have the pharmacy make all of those drugs? And they did that. And the infection rate 6 months later was from 70% to 24%. And the mortality rate dropped in the neonatal ICU. So just, you know, that's before resistance. But of course, that was going to build resistance. It was going to become a problem eventually with that high of an infection rate. And so there, you know, so that group can sit down and talk about that together and bring their ideas. A pharmacist brings their idea to that group, and you can make a big difference in things. So
thank you so much, Prof. Lander, for the recommendation. We have one question. one last one, maybe a quick one.
It's fine. Yeah, sure.
Because it's quite in the evening for you, so we feel quite bad.
No problem. It's no problem.
Okay, one last question. In America, when you have a AMR issue, antimicrobial resistance issue starting, did it become the attention of the people or the regulators, and do they use do they actually control the antibiotics usage, or did it start from did the movement start from the hospital, individual hospital, regulator versus the individual hospital?
Well, it really was kind of both, but I would say the movement really started from the individual hospital. And then, as you all probably know, because I think you also have a similar thing, the accreditation organization here in the United States is called the Joint Commission on Accreditation of Healthcare Organizations. Once that sort of started, as we saw bacterial and fungal resistance becoming a problem, and some hospitals started trying to develop plans to deal with it, then the Joint Commission picked that up as a theme. And they don't really force people to do a certain thing, but they come and they look at your institution as, I think, the same thing there in Indonesia, and then they make fairly strong recommendation. You have to try to improve your situation. So, and they, in the US, they didn't, the Joint Commission did not do that by mandating to the hospital, like specifically which antimicrobials they could use. It was more of, you have X% resistance. Over the next year, work to lower that to this percent, and then the next year, this percent, kind of thing. And so they help the hospital set goals of what they want to try to achieve over a period of time. So, and in the US, the Joint Commission is pretty powerful, because if a hospital does not keep their accreditation status, they have trouble being paid to take care of patient by our insurance systems. And so it's fairly powerful, but they don't really just necessarily say, you have to do this, kind of thing. It's more a, so you might have 20 different patients that you've had over a year that had a different bacteria and different types of resistance problems. And they don't say you have to treat those with X drug. They say you need to reduce the number of those over time. So.
Thank you so much, Prof. Yeah, I think a good thing to know that GCI has so much, influence. And I think Fitria's Hospital is actually GCI accredited too.
Yeah.
RS Cipto. All right.
Well, and Ms. Trisna, that was the director at one time at Cipto in Jakarta, I think she is very involved, I believe, with the accreditation organization, I believe, in Indonesia. So,
okay, so maybe Annie will get you to have one last take-home message, Prof. And after that, let's have a photo session.
Okay.
Yeah. Do you have any take-home message for anyone? Everyone? We have about 40 people here, 40 odd people.
Yeah. I think the biggest thing I would say is try to really, and this is a good area. I mean, like, try to find an area where you feel like you can have an impact. And it's a great idea, to have a group like this where you communicate with other pharmacists around your country and decide what kinds of things you can help each other do. And, Zoom or even better, something like LinkedIn or Facebook, some kind of mechanism for you to share, like articles and ideas, is a real positive thing. That way you learn quicker. You increase your ability and skill faster as a group than one person can by themselves. And so, and then, wherever you work, if it's in outpatient, inpatient, and you all may already know this, but it will amaze you how much the problems that you are dealing with are the very similar problems to 2 or 3 other people that are on this same phone call, right? And so forming those groups and even subgroups to try to deal with the resistance pattern in the situation where you are is a very positive, powerful way to do that. That's people ask me, well, Prof. Lander, you're from America. Why did you want to develop the Asian Conference on Clinical Pharmacy, right? Well, I did that because I realized the benefit of those pharmacists from different countries getting together to be able to talk about practice and how do I improve? How do I learn more about patient care and patient situations? And that, people say, and I still even, it's 2021. So I still have people ask me, Professor Lander, I wish I could practice in America. And I'm like, why would you want to do that? I'm like, your country, Indonesia, is a great example. The difference between the practice of the pharmacist that I saw the first time when I came in the year 2000 and the last time I was there in, 2017, maybe 3-4 years ago, is amazing. It is, you have developed clinical pharmacists much faster than we did in the United States, okay? And people look at me and say, really? And I'm like, really? My teachers learned clinical pharmacy in the early 1960s. So the United States has been doing it for 60 years. But there's still not a clinical pharmacist in every hospital in the United States. Okay? Far from it. Okay? So we're still developing clinical pharmacy. And so, every country I go to in Asia, I am just, amazed at what you all have been able to do. And so that's the thing to me is, and I think that's partly why, because you've all worked together to try to develop things and you share information and you're all very interested in learning and understanding better. And of course, the US is a completely different place with a lot of different issues that are different, but it's, you can make a lot of change in your lifetime as a pharmacist in what happens in your country. And so I'd want you to never forget that, to always remember that you've got that ability to do that. So, it's interesting here. Of course, I still teach and I have students, and students often say to me a similar kind of thing. It's like, Professor Lander, I'll never be as smart as you, or I'll never be able to do as much as you. And I'm like, that's a ridiculous statement. Because by the time you've been practicing 40 years, you will know a whole lot more than I do right now. See, because it's a different time, right? So we're progressing all the time. Just like, when I first became a pharmacist, I never dreamed of being able to genotype a bacteria from a culture swab, right? It's being done now, you know? And so as a pharmacist, you have to learn what does that mean? What's the difference between this bacteria in this patient versus a different bacteria in a different patient? And you know, the difference, I don't see the difference because I have to wait 3 days for it to grow out on a culture plate. But, you know, in the near future, we'll all be looking at it 20 minutes after the patient arrives for treatment. And so that's the thing, teaching people, all right, what kind of antibiotic are you going to use then when you have that information? Instead of, okay, which 3 antibiotics do I have to give a person to try to cover what they might have? It'll be a whole new game, right? And so that's, you know, that will that'll make a, you know, it'll change the way you have to practice. That's the other thing about learning everything you can learn, is because it'll be different before you know it, you know, kind of thing. And that doesn't mean at all that you won't still be able to use the knowledge that you've gotten before that happens, right? Because you will. That's the other amazing thing to me, you know. If I see a diabetic patient, I understand them better today than I did 30 years ago, because we collectively know more about diabetes and we have better drugs to treat diabetes than we had 30 or 40 years ago. But I still am able to use what I learned even as a student about diabetes. So I know that was a long answer to your question. I talk a lot sometimes.
No worries, Prof. Thank you so much for the sharing.
I think that's, you all have the ability to do whatever you want to do. You know, right. you can define what the future is. So, and I didn't used to believe that myself 40 years ago, but I do now. I see that in you all. So I didn't believe that about myself. I'm saying, not about you. I didn't believe that about myself, but you know, so being old, I guess, has its advantage. I can see that now. I can determine that now. So
thank you, Prof. Thank you so much.
Thank you all. Thank you all. So,
yeah. So can we ya teman-teman on kamera, terus kita foto bersama dengan Prof Lender. Okay, Prof. We have 40 odd people, so all over Indonesia, and we are very thankful. We are able to save $2,500, $2,000 USD per person. If we were not,
okay. Yeah.
Otherwise, we'll have to visit you.
Yeah. Right.
Yeah.
All right.
Okay, teman-teman. Yep. Sorry, Prof.
Yeah, and I hope we see some of you virtually for the Singapore meeting in July.
Right.
Yeah.
FCCP.
Okay.
Yeah.
All right. And I'll be glad to do this, you know, again, if you'd enjoy it, that'd be great. So
we enjoy it very much.
So, okay. All right. Yeah. Thank you all.
Thank you all.
Have a good evening.
Yeah. Wait. One screenshot
okay.
for a while. Yeah. Ready? 1, 2, 3. Smile. Okay. Another one. Another page. 1, 2, 3. Smile. Okay. 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 Thank you, Prof. Thank you so much, and have a good day.
Thank you, Prof.
Yeah.
Stay safe all.
Thank you. Thank you.
Maybe we will have another meeting, Prof. Just so happy we met you. Terima kasih banyak teman-teman semua. Jangan lupa follow Instagram kami ya. Besok kita ada live show. Jadi @apoteker.amr.
Yeah.
Thank you, Prof. Bye bye.
Thank you, Prof. Bye.
Have a good day.
Yeah. Bye bye.
Have a good evening. Bye bye.
Stay safe all. Stay healthy.
Stay safe. Thank you.
You too.
Bye.
Boleh kita ending meeting ini, tidak apa-apa Kak
Iya.
Kevin.
Saya
Terima kasih
end
banyak
ya.
ya semuanya.
Yuk,
Ya, terima kasih semuanya.
Bye-bye.
Sehat-sehat. Bye. Terima kasih Kak Noel.
Halo,
Thank you ya Kak.
sama-sama.
Terima kasih.
Selamat pagi semuanya.
Oh, Prof. Terima
Halo.
kasih, Prof.
Terima kasih, Prof.
Saya bukan prof.
Oh. Siap. Terima kasih Pak Suryadi.
Iya.
Mohon izin kita ending acara hari ini ya. Nanti sampai bertemu di acara Apoteker Peduli AMR berikutnya. Besok kita ada Instagram live show. Kita belajar how to bagaimana menjadi presenter yang baik. Nanti ada Apoteker Nanda dan Apoteker Nadia sebagai hostnya. Nanti akan kami upload di Instagram kami @apt.peduliamr. Dan ada beberapa schedule di bulan Mei, nanti juga akan kami upload. Termasuk event besar kita bersama, insya Allah di tanggal 29 Mei. Nanti kita akan kerjasama dengan beberapa stakeholder. Terima kasih Kak Kevin, mungkin kita bisa end.